Great. Well, I see some numbers beginning to dwindle. Hello, everyone. And thank you so much for joining today's webinar, Emerging Respite Care Strategies and Medicaid Home and Community-Based Service Waivers. I'm Kimberly Hodges, a Policies Associate here at NASHP, and I will moderate today's webinar. Next slide, please. So today's webinar is a result of key informant interviews we conducted with 7 states on how they both structure and administer respite care. From this report, we outlined 6 emerging respite waiver strategies based on this body of research. We are so fortunate to have state officials from Kentucky and Virginia to share their approaches and strategies they employ in administering respite care for their older adult and those with physical disability populations. So it really is our hope today that you all will come away with tangible strategies to increase respite service access in your Medicaid HCBS waiver programs. Next slide, please. So for our agenda today, I will provide a brief overview and state examples of the 6 respite care strategies that states can implement for older adults and adults with physical disabilities. Then Pam Smith, Division Director of Long-Term Services and Supports at Kentucky's Department of Medicaid Services, will outline Kentucky's approach and their HCBS waivers to administering respite care. Then lastly, Nicole Martin, Director of the Office of Community Living, and Jason Rachel, Director of the Division of Integrated Care, both housed in Virginia's Department of Medical Assistance Services, will offer Virginia's approach to administering respite care in their HCBS waivers with an added managed care lens. And at this point, I would also like to thank our funders for their support of NASHP's work in family caregiving, including this webinar. They are the Administration for Community Living and the John A. Hartford Foundation, and this webinar would not be possible without their support. Next slide, please. So I need to cover a few logistics before I begin my presentation. We have reserved some time for questions at the end of the webinar. You can send those in the Q&A feature, but don't feel like you have to wait until the discussion time to send in your questions. Instead, please feel free to send them as they occur to you during the presentation. And then we will respond to your questions during that question and answer time. Additionally, if you would like to access closed captioning, there is a button at the bottom of the screen that you all can press. And lastly, the webinar slides and the recording will be posted to our NASHP website, so you can look out for that. Next slide, please. And with that, I will turn to my presentation. Next slide, please. So to set the big picture and provide context of respite care and how it's delivered in HCBS waivers, states typically define respite in their waiver applications as a service delivered in the home or a facility-based setting that provides short-term relief for caregivers. In 2022, NASHP conducted a 50-state policy scan, and we found that 47 states and DC cover respite in their HCBS waivers that serve older adults and adults with physical disabilities. However, I will note that states can administer respite care outside of Medicaid through programs such as the National Family Caregiver Support Program and the Lifespan Respite Care Program. However, Medicaid really is a large public payer of these long-term services and supports, and states' varied program policies and rates greatly affects caregivers' access to these high-quality respite services. Next slide, please. So it's also important to take a step back and consider the why behind these policies, both respite's importance from a caregiver standpoint and what the recent research literature concludes about its benefits. NASHP conducted with the University of Massachusetts at Boston and Community Catalyst a series of caregiver listening sessions. And one key theme that really stemmed from these conversations with caregivers was their desire for respite services. Additionally, research studies conclude that access to respite services really improves both the physical and emotional health outcomes of caregivers, delays older adults' nursing home placement, as well as decreases hospital readmissions and emergency room expenditures. Next slide, please. So here is a nifty infographic that outlines the 6 emerging waiver strategies to increase respite service access. I will be highlighting briefly a broad overview of each of these strategies with state examples, and then we will hear from both Kentucky and Virginia on their approaches. But they include awareness and education, various respite service types, flexible respite policies, self-directed options, leveraging managed care, and lastly, payment rates and structures. Next slide. So the first strategy that our study states employed was that they all really recognized and instituted outreach processes to increase awareness and educate individuals and their caregivers about respite's availability and importance. They did this through either naturally embedded opportunities, such as instructing case managers to educate caregivers during intake appointments, to more targeted initiatives to reach culturally and ethnically diverse populations, such as Washington State. They're currently in a pilot for training and education for family caregivers of the Skalam tribe to become respite providers. Next slide, please. The second strategy that study states employed was offering numerous types of respite care. So while most states typically offer respite as a singular service type or differentiate by service location, such as in-home or facility-based, a few states, such as Missouri and Iowa, for example, really tailor their respite services to more closely meet the service needs of the individual. So this includes offering both basic and advanced/specialized respite, really with the key difference being the provider requirements for advanced and that specialized respite requiring clinical training and staffing. Additionally, as you all see on the table there, Iowa also offers group respite. And as states are really, as you all know, really dealing with the direct care workforce shortage, Iowa's offering of group respite can provide an example for a workforce strategy that states can institute. Next slide, please. So our interviews with study states also really reinforced the flexible respite policies they designed. And their goal is really to minimize any disruptions in caregiving. That was very clear from all of our discussions we had with them. As we know, an individual receiving services or their caregivers can face many changes and their service needs can vary accordingly. So the first flexibility category that we observed was the pooling of respite dollars and units within an individual's self-directed budget and service plan. So for example, here, Iowa and Washington use this flexibility, with Iowa allowing unused respite dollars to be reserved for future respite purposes in a savings plan. While Washington, on the other hand, permits the pooling of respite units up to 6 months for future use. And additionally, a few states also package respite and personal care to really maximize a service's benefit. So for example, Missouri directs individuals, if applicable, in an individual's person-centered care plan to use personal care first and then respite care after to fill in any remaining gaps. From a workforce strategy perspective, Louisiana allows the same providers for both respite and personal care. Next slide, please. So study states also craftfully designed their self-directed options to really more seamlessly integrate family members and friends into the direct care workforce as respite care providers. So this can be used by states to supplement the lack of agency hired respite providers, and really equally important in allowing an individual to pick who they would like as their service provider. So for example, Iowa allows for really flexible employer discretion to set their own training, experience, or qualification requirements within the necessary safety guardrails. So in talking to the state official from Iowa, they said that this really facilitates a more simpler hiring process for family members and friends to receive payment for providing respite. Next slide, please. And so study states who utilize a managed care delivery system really leverage partnerships with their managed care organizations to increase respite service limits and expand the eligibility pool. So state examples include Texas, which allows for MCOs to include respite as a value-added benefit for those not enrolled in one of the state's Medicaid waiver programs. Additionally, Iowa allows their MCOs to increase respite service limits for members who have already met that respite service cap. Next slide, please. So for the sixth and final emerging waiver strategy, we have respite payment rates and structures, and these really can influence a provider's willingness to offer respite. As we know, providers are an integral component to the service ecosystem. So study states really use provider incentives, such as Washington State's additional administrative reimbursement rate to incentivize that respite provision. As you all know, we have seen these provider incentives most notably during the COVID-19 public health emergency, where states have used, the American Rescue Plan Act dollars to increase their rates. And I will note that NASHP is monitoring closely which states plan to sustain these rate increases now that we are in the post-public health emergency period. Next slide, please. So in sum, here are a few key considerations if you are looking to increase respite care in your state. You will notice that a lot of these are not big sweeping policy changes, but rather really intentional steps that can really make a big difference in the life of a caregiver. This includes educating caregivers on respite's availability. They might not even know that the service exists. Tailoring respite services to better match an individual's acuity level, expanding self-direction, designing flexible respite policies to minimize any disruptions in caregiving, leveraging managed care partnerships, and crafting payment rates and structures to really incentivize their respite provision. Next slide, please. And with that, I will turn it over to Pam Smith from Kentucky to outline Kentucky's approach on emerging respite care strategies and their HCBS waivers.
Thank you so much. I go to our first slide. So my name is Pam Smith. I am the Division Director of our Long-Term Services and Supports Division within Kentucky Medicaid. We oversee all of our 1915C HCBS waivers, as well as other long-term services and supports for our Medicaid fee-for-service population. Next slide, please. So we, in Kentucky, we have right now 6 home and community-based waivers. We have 5 of those that offer respite as an option, and 1 waiver offers 2 types of respite, which is the one I'm going to speak most about, which is our home and community-based waiver. I know, novel name considering that all of them are home and community-based waivers, but some time ago, which I've been involved with the waivers for 29 years. So it was actually before that, it was one of our first waivers, and somebody thought, wow, it'd be a great idea to name it HCB waiver, not knowing later how confusing that would be. It is one of Kentucky's most requested services. We had nearly 7,000 requests and authorizations in 2022. And that is in our HCB waiver alone. It is one of my my team jokes. It's one of my soapbox items. When we are speaking to individuals and speaking with case managers, often talk about how important it is for someone to be healthy themselves, and you can't be an effective caregiver if you are exhausted yourself. So it is something we talk about quite frequently. Next slide, please. So our education has really taken two main streams. One is with our case managers. And so we talk about this when we're doing education about person-centered planning activities and really advocating, okay, what services do you want to talk to an individual about receiving, and making sure that they understand the importance of respite. And as again, as I said, stressing the importance of caregiver relief, not just for the benefit of the caregiver, but also for the participant, because, especially emerging out of COVID, being stuck in the house with the same people 24/7, 7 days a week, sometimes doesn't go very well. And we all just need a break from each other sometimes. And then also the importance of them helping to assist with identifying respite providers. That includes what option is going to be best for them. Is it a traditional provider? Is it to self-direct, where they can hire maybe their own family member or a friend to provide respite? Or is it an option that is provided at an adult day health center, or potentially a short stay in a nursing facility? As far as community engagement, we speak about it many times. It's one of our topics when we are doing just provider education and just town halls, but we work with a lot of different support groups, councils that support our waiver populations in the state, and different coalitions on the importance of respite and the waiver services in general, and get their buy-in and get them to be champions of the service, so that they help individuals that come to them understand what the service is, how they can get it, and how to use it for their benefit. Again, with them also stressing that importance of the caregiver relief and what the benefits are for both caregiver and participant. And then we like to get them to help us spread the message to members and families, because we found a lot of times when we send, we joke that when things come in that envelope that has our new logo now, the Team Kentucky, before that it had a horse on it, that when people got correspondence and that they didn't want to open it because that was bad news, right? So we've tried to be very innovative on how we can communicate with people so that they get the message and they don't just avoid written correspondence from us. Next slide, please. So our strategies in Kentucky, and again, this is focusing on that HCB waiver, which it's our largest waiver. We can serve a little over 17,000 people. It targets individuals that have a physical disability or that are age 65 or older. We have a lot of individuals that are medically complex or medically fragile in this waiver. And in that vein, we offer really two different types of waiver. So we look at non-specialized respite, which is really, this is more in the self-direction population. It really is for those individuals that do not need any type of skilled care or skilled oversight. It focuses on self-care and just kind of the safety, as well as recreational needs and supervision needs. We've had some individuals, especially some of our younger individuals, that during respite visits, they may go to the park, or they may, it may be something in the community, versus them kind of the traditional thinking that it's somebody that comes in the home while the caregiver leaves. Our specialized respite is done by provider managed agencies only. We have two levels based on the individual's need, and the skill level of who provides it is really targeted to that individual. So it can be anyone from your direct service worker with access to a skilled professional, or it may be a nurse that is actually providing respite for that individual. Next slide, please. So again, this is talking about our level 1 and level 2. KHAT is the tool that we use. It's the Kentucky Home Assessment Tool. It really captures down to the individual needs of the person, you know, their behaviors, their toileting, their medication needs, whether they have injections or they have it's just oral medications, the number of PRNs that they may have, really to help the case manager and our individuals that are reviewing services to determine what is the most appropriate level of specialized respite for that individual. Next slide, please. Our rate structure at this moment, we are actually in the middle of conducting a rate study. Our traditional rates right now are, as you can see on the screen, we are looking at these rates will be increasing. We did, through Appendix K, allow for respite to be billed at a higher rate to direct some of the workforce issues that we were having. And we, similar to some other states, also allow, in particular with PDS, sometimes you will see the same worker will be the individual that delivers respite as well as any type of personal care or attendant care services. We also encourage individuals to think about not just, so how can you offer an individual respite outside of just the respite service? So is that maybe in an attendant care service? So if you have an individual that requires more of that intense supervision, encouraging family members that even if they don't work, that they can access attendant care if their individual needs those services, or personal care, maybe even just a couple days a week, that gives them a break so that they're not doing it 7 days a week, but it also gives them that break, similar to respite. Next slide, please. Right now, our limitations, we look at $200 a day or up to $4,000 per year, but we are looking at that right now in the midst of the rate study, based on what our increased rates will be. As I mentioned, using attendant care to fill in the gaps if those maximums are reached, and really depending on the needs of the individual, because to us the message has been that it's more important for them to get the service respite or the intent of that service respite, even if sometimes it's not called respite. Looking at other community resources and natural support. So we like to work with the case managers and with the families. We staff a help desk that individuals can call, and we will help them to find other resources that maybe they can't find a respite worker at this point in time. We all know right now that there's a direct service workforce shortage. So, you know, looking at how can we help them to cover respite needs? What are some ideas that other individuals have used? What are other community resources that they can access that may not be paid through the waiver, but still will help them achieve the same benefit, which is that rest from the daily caregiving needs. The next slide, please. So all of our waivers that offer respite, we do use that we use participant directed services model as well as traditional, where the participant can hire their own non-specialized respite worker. That's been especially important when we think about the children that we serve. Parents typically, and I can understand this as a parent, are, you know, it's uncomfortable to have someone come into your home that you don't know and you're going to leave your child with them. So the participant directed model a lot of times is more appealing to them because they get to help in, you know, they get to look for that worker and they get to feel comfortable with the worker, including sometimes maybe it being a family member or it being a neighbor or somebody that's familiar to their child. Same thing even with older adults. You know, it can be uncomfortable when we meet new people. So it's worked, it has worked well. And I will say we have a large, I think we were reaching across all of our the 5 waivers that offer participant direction. We have about a 70% rate where our participants use participant direct at least one service. So we've seen it used widely. It's helped with the shortage that traditional agencies have had in hiring workers. And it really just, I think, makes individuals feel more comfortable a lot of times in leaving their participant alone, or letting their participant or their family member to be in the care of someone else. I think that it gives them more reassurance. So I realize I went through that really fast. I typically have a habit of speaking fast. So I look forward to maybe some questions if you all have those at the end. At this point, I am going to hand it over to Virginia and to Nicole.
Thank you, Pam. My name's Nicole Martin. I'm from Virginia Department of Medical Assistance Services. And today we're going to talk about our approaches to respite in our home and community-based waiver services. I'm the director of the Office of Community Living, and we oversee the 1915C waivers and also specialize in our consumer-directed program. And then later, Jason Rachel is going to talk to you about our managed care program. Next slide, please. Virginia has four 1915C waivers. One is the Commonwealth Coordinated Care Plus waiver program, which is what I'm going to focus on today. And then we had three developmental disabilities waivers. In fiscal year 2022, we served 62,000 participants in our waivers, and 38,000 of those individuals received respite services. So it's a bit over half that are actually receiving respite. Next slide, please. Okay. Respite, for us, we defined it as services provided to waiver individuals who are unable to care for themselves that are furnished on a short-term basis because of the absence or the need of relief for the unpaid primary caregiver who normally would provide the care. We offer respite through our traditional agency model, and then we offer it also through our consumer-directed model. Some people opt to have a combination of both, where it may work better to have consumer-directed respite for certain times and traditional respite for the others. We do have a 480-hour per year limit on respite. So that would be if a person had a traditional agency and consumer directed, we'd add those hours together. So no one would get more than 480 hours a year. And we do also offer respite that is non-skilled, but we do have a skilled respite option that's available for individuals who have complex medical needs. The skilled respite is provided by registered nurses or LPNs, and it's available only through our traditional agency model. Next slide. So for Virginia, respite and personal care are very closely tied together, and for a number of reasons. One, when an individual needs comes into our waiver programs, and personal care is the largest service that we have, we look to see, if the person has a personal care need, they often have an unpaid primary caregiver. So we know that respite is likely also needed. So we anticipate that and often approve respite and personal care together. And as it was mentioned in a lot with some of the other states, the respite is episodic in nature. It can be used as a supplement to our personal care hours. There are often times where, personal care hours may be 8 hours a day, and maybe temporarily the primary caregiver might need a couple extra hours in the evening, those can be added to those respite hours can be added to the personal care, and it can be provided by the same caregiver. Generally, if there's an agency involved, the agency will have the same aide provide respite and personal care, same way in consumer directed services. Reimbursement rates for respite are the same as personal care. So that's been nice because it not only gives an incentive for the providers to offer respite, but if there is a rate increase for personal care, then there's also a rate increase for respite. As Virginia, with our ARPA dollars, we did do a rate increase of 12.5% for both personal care and respite, which has been made permanent. So that's been nice for the providers to have that bump and pay. Next slide, please. Respite is pretty popular through our consumer directed program, and it is really offered generally by family members and friends. And it's nice because the training requirements for consumer directed services are not as intensive as they are for traditional services. In consumer directed services, the training requirements are set by the employer or the waiver participant. And it can be tailored to what their needs are. And so that's been really attractive to folks. So more than half of the people who are using respite in Virginia opt to do it through consumer direction versus our traditional agencies. Next slide, please. Okay, I'm going to actually turn this over to Jason Rachel so he can talk about how respite works in our managed care contracts, and we will give it to Jason.
All right. Well, thank you, Nicole, very much. Good afternoon, everyone. My name is Jason, and it's a pleasure to just take a few moments of your afternoon to talk through how Virginia took our respite program that was in a fee-for-service program model and move it to managed long-term services and supports program. We took this dive into managed long-term services and supports back in 2017. And as I'm sure many of the participants on the call this afternoon have some experience with kind of working with vendors, it really starts with a good partnership between yourselves as potentially the regulatory agency, the funder, and the vendor, and that's no different here with regards to our managed long-term service and supports program that we fondly refer to as the Commonwealth Coordinated Care Plus program here, and it is again with that partnership. Is kind of one of those key milestones or key factors in how we rolled the program out, and specifically how we rolled our respite care program out to our health plans. And then secondly, I would say communication is again another key factor in building that partnership with the health plans. And it starts with, or the foundation is laid down by a strong contract, and strong in sense of clear and articulate in what we are expecting. And again, as you can see here, I pulled a snippet of our contract around respite care to show, to let the health plans know what respite care is, where it can be provided, how it can be provided, and then in that last section there, some of the parameters around it. So again, but I'll be honest with you, there's pieces to it, that go beyond kind of the nuts and bolts, and you really kind of want the intent, right? The intent of our respite care program. And as Nicole mentioned, and even Pam, and Kimberly in her opening remarks, we wanted to keep that intent of accessibility to managed care, to that connection to personal care, and how that can be utilized by members, and how we expected or expect the MCOs to administer this program. So we did that through a particular way. And if I could have the next slide. Through, as you could imagine, extensive education with the MCOs, specifically their operation folks around those in the utilization management area, and then the claims. And again, we wanted to make sure that the plans were very clear on, again, what the program was, and our intent, and kind of how we wanted respite to be administered through our MLTSS program. And we did, again, I wouldn't say it's particularly novel, but I will say that it was highly productive. And that is, we hosted stakeholder meetings at the onset of the program, kind of prior to and early on, with providers, the health plans, and of course, DMAS staff to moderate and I was going to say referee, but that sounded too contentious. But to have a productive conversation around kind of gaining some consensus and some standardization in how respite was to be administered by the health plans. And I bet there are some of you out there that have convened stakeholder work groups and dreaded that activity with regards to knowing and anticipating heels being dug in and lines being drawn in the sand, and just different viewpoints and different perspectives, and hey, I get it, right? Consensus is sometimes really hard to build, and we knew that going in. And we didn't want it to be a series of meetings where everyone just dug their heels in and kind of and weren't willing to budge. And so we came at it from the perspective of, we have to deliver this, or we have to create, this deliverable that unfortunately we don't have creative names here, but it's clear and to the point. It's our how to do business with MCOs respite document. And that was the goal of these meetings, is this has to be created. And it was very interesting. I will say that there was some majority rules aspect of that work. There was some peer pressure with that work, but it all was driving towards creating this deliverable, and that sometimes that last health plan had to kind of give, sometimes that last provider kind of had to give, but they knew it was kind of for the greater good of creating this standardization and this consensus across the providers and the health plans that would provide an opportunity and provide our goal and our intent as the regulatory agency to offer the program of respite as we designed it, and being highly accessible and highly connected, and not to get so bogged down by the mechanics, right? The mechanics of which form or which codes, and really let that not be the hurdle, right? We didn't want that to be the obstacle. And so the how to do business with the MCOs around respite is available on our website. It stays there for providers and plans and stakeholders to access at any point. But it walks through those key points of the mechanics of administering the program, to say, this is the form, and look, all the plans are using it, right? And so there's no variation there. They're using the same codes to request and to bill for respite. They're using the same authorization time period, and that kind of an added bonus with regards to, I just speak for a moment about building trust, right? Building trust between the LTSS providers and the MCOs, and realizing back in 2017 that our LTSS providers in the great Commonwealth of Virginia didn't have a lot of exposure or experience from a business side, certainly, of dealing with MCOs. And that some of our MCOs, quite honestly, didn't have a lot of experience in dealing with LTSS providers. And so these work groups really had an opportunity to start building that trust and get one element that we required through the contract was around timely clean claim payments, and set that at 14 calendar days, so that there was some trust that would be generated, across from the via the provider and the MCO around ensuring that when they, the health plan would follow the standardization, the provider would follow the standardization, and that provider had confidence that and trusted that when they submitted that clean claim, going through the same authorization process, using the same form, and billing for the same codes, that they're going to get paid timely. And and I'll say that it was really that has been there were some tough meetings, but in the end, we really were able to take the respite program that Nicole, my colleague, and her team created, and really just delegated that responsibility to the health plans in, I'll say, relatively seamlessly, with regards to administering it very nearly identical as we would in the fee-for-service program. And that really did, at the end of the day, continue that accessibility that we were striving for with regards to access to respite care, and quite frankly are very happy with the outcome. And then just one quickly, great, thank you very much. I appreciate the gentle hook. Is that the document, while maintaining its kind of public aspect, has been helpful post the creation of it. So now we're in 2023, and so that's a 6-year-old document, and we've updated it from time to time periodically, and we've used it. The providers have used it when they're new, and that the health plan has used it when kind of looking towards how should we expect this, and that we've used it when one or the other isn't following the playbook, right? Wait a minute, why did you use that code? That's not the standard code. Or wait, why did you deny that authorization request when they used the right form? And so it's been a very helpful in that way too. So I will stop and thank you all very much, and turn it back over to Kimberly for questions. Thank you, Kimberly.
Great. Thank you so much, Pam, Jason, and Nicole, for those excellent presentations. We will now transition to the question and answer portion of today's webinar. Please submit any questions you have in the Q&A box at the bottom of your screen. We already do have a few coming in. And Pam, this is first for you. Someone asked for medically fragile children for their respite reimbursement rates. Are they the same as adults, or does Kentucky recognize a higher level of still needed for those populations?
So based on even whether it's a medically fragile child or it is even a medically complex or fragile adult, the levels of respite, so we do, they are tiered. So specialized respite level 2 is our highest level of respite, and so it is reimbursed right now at $10 per 15-minute unit. But as I mentioned, we are going through a rate study, and I expect that rate to change. But yes, we do, based on the level of need and the skill of the worker that is needed.
Great, thank you. And then this is for Virginia. We had a question come in. Can you offer an example of how / why an individual might combine the agency provided and consumer directed respite care?
Sure, I'll take that one. So an example could be, perhaps there is a member that's using personal care through our traditional agency model. But perhaps maybe on the weekends, there's a family member that may want to be able to provide respite care. Instead of that family member having to be hired through the agency, they could use consumer direction in that manner. And so the provider works along with our services facilitators for our consumer directed model to coordinate that to, whether it's 240 hours for agency and 240 for consumer direction. They work together based on what the individual is requesting. So that's one reason why they might do that.
Great, thank you. And then this is for both Kentucky and Virginia. Are you seeing any respite opportunities or providers in your state for children and adults with intensive behavioral health issues?
Nicole, I can answer first. And we are 4 of our other waivers. So 2 of them actually target individuals with intellectual and developmental disabilities, as well as we have 2 waivers that target individuals with acquired brain injury. So it is not unique for us to see individuals that not only have some of the typical self-injurious behaviors, destructive behaviors, but also elopement, just some unique challenges based on their diagnosis. So we, really have looked at what types of worker we also offer. I will mention in those participant directed is offered, as well as traditional or an agency provided respite, but really looking at what kinds of education is important and training is important. We also see, which I don't think would surprise anyone, a lot of individuals that use participant direction because a lot of times family members or friends may know, be able to work with those individuals better or understand those behaviors, and may not, unfortunately, get as frustrated with an individual that may exhibit some of those behaviors. So we've seen a lot of luck with participant direction for individuals that have kind of some unique challenges.
Yeah, and for Virginia, I would say that would be the same thing, that self-direction is usually the go-to in those cases, but we also wrap around other services such as therapeutic consultation that can help support either agency staff or family members with some interventions that would help address some of the behaviors.
Gotcha, thank you. And then this is also for Kentucky and or Virginia as well, but how do you handle the respite needs of the paid family member? We find that many caregivers who are paid actually provide far more hours than what they are paid for. So this individual gave an example of being paid for 30 hours a week, but really providing care 24/7, and that they just really need a break.
In Kentucky, the way that we address that is in particular, we look at, because this was a challenge for people kind of in particular, our kind of case managers and support brokers to wrap their head around. They're being paid to take care of their individual, but as you mentioned in the question, they're providing care 24/7. We're not paying them 24/7. So we do allow them to have respite as a service as well. It is, it can't be during any of the, their schedule or their plan of care that they normally would be working, but we do make sure that those individuals have an opportunity to access respite, as well as encouraging them to look at onboarding additional employees to help with that, even if it's so that maybe they're not providing service 5 days a week as a paid employee, because they're there, as you mentioned, 24/7.
Great, thank you. And then there are also a few questions in the chat just about emergency respite, specifically one relating to homelessness. And I can give, sort of like a 50-state broad policy perspective, but specifically for HCBS waivers for older adults and adults with physical disabilities, there's not a lot of homelessness interventions specifically for respite integrated into the waivers. We have seen in general this trend, especially in the 1115 waiver demonstrations, where they are beginning to incorporate some homelessness supports. I'm thinking of Arizona and their cost containment waiver, their 1115 waiver, and how one of their service packages really tailors to those at risk of homelessness, but specifically for respite. Unfortunately, right now, we don't see that much of that from, a broad perspective. I do know that there are some councils and coalitions really pushing for that. For example, I know that there's like a medical respite coalition that again is really trying to push for more of those services in our healthcare system. And then another question that we have is what tips and this is for Kentucky and Virginia, what tips and advice would you give a state official who's really looking to increase access to the service, through an HCBS waiver?
I think for Virginia, like I talked about how we package respite with personal care, really talking to support coordinators or care coordinators, whoever is actually in charge of developing that service plan, to make sure that they are offering respite and that members are aware of it. So really just that education piece, that it even exists.
Yeah, I would echo Nicole. I think education is the key, and also utilizing your your advocates in those agencies to help them kind of get that message out to individuals so they can advocate for themselves. And when they meet with their case managers or their support broker, that they ask the question themselves about respite or just as services in general, so that they are as knowledgeable as possible.
Great, thank you. And then another question is, and I know you all briefly talked about this, and Nicole, you as well, with how a lot of people really use self-direction for the service, but from what you all have heard, how does respite in your waivers positively impact those in your state? And do you think there were any specific policy or regulatory action that contributed to this?
For Virginia, I think it's the flexibility that positively impacted respite. And then, we have 480 hours. So when people are applying for respite, they know how much they're going to get ahead of time. So, that could be good or bad, because many people could say that 480 hours is not quite enough. We did have a higher limit at one point, and it was decreased by our General Assembly. However, I think knowing ahead of time what's going to be approved is also helpful. So yeah, the flexibility and just very transparency in what's available.
I would echo what Nicole said.
Great. And then Jason, this might be more of a question for you. We're getting some comments that they're very impressed with the MCOs in Virginia and your work with them. But were there any major, sticking points with these MCO discussions? And do you have any tips for working with them?
No, great question. So I think what's important to remember, or at least maybe the perspective to consider, is when you bring in managed care, you're typically bringing in a number of MCOs, and you're looking for them to bring their, what are they bringing unique and special to the table, and then allowing this push-pull around kind of competitive advantage, and allowing them to be kind of individual plans and offer kind of a different experience, certainly they'd argue a better experience for the member, but that and I think you have to make space for that as a regulatory agency. But I've come to believe and see it on a day-to-day basis that shouldn't be for everything. Right, that doesn't have to be for everything. That standardization in some areas is really the key to the program, and that hey, MCO 1 and 2, you can be distinct and different here, but on this point, there's really no competitive advantage that you're losing by standardizing, and the gains that you're going to make by making an adjustment to your system to accept the DMAS 98, which they've never seen before, until we told them they had to use it, right? The effort put there, in the long run, will really make the program better and make the experience better for members, providers, and subsequently members. And so I think that's really, but maybe one, that was kind of an obstacle on, that we had to kind of overcome with the health plans. And on the provider side, there was that give and pull too. Like, look, it can't be fee for service through 5 different health plans, right? It can't be that. It has to be, we have to allow for that individuality and that uniqueness. And so it was having those conversations. And I apologize if I didn't answer the question directly, but I hope I gave some insight into kind of how to navigate those discussions, between providers and the health plans.
Great, yeah, thanks so much for that information. And then we probably have time for one more question. Thank you all for submitting them. But in general, I just said, what measures do you all use to document the impact of the service on the caregiver or the care recipient? Is that usually in at a regional level or more broadly?
I would say for Kentucky, honestly, it's one of those things, as we're in that continuous quality improvement loop. Measuring that is always a, how can we do that better? Some of the things that, we look at is incident reports. It is the feedback on our goals and objectives for the individuals, on our care plans. But I think it's something we're continually looking at. How do we measure what kind of impact that that is having, both on the participants' life, but just in general on the health of the family? So I know that kind of was a very generic non-answer, but to be honest, it's something we're continually looking at. How do we measure that better, and what is the right measure for that?
And I would say too, just from a 50-state stand perspective, that is something that I think all states are continually to work on and improve, and it's very hard to measure that. We know that some states do use, caregiver surveys. So that's one example. But I think that's something that we might not always reach that end goal, because we always want to receive feedback for what we do. But yeah, great question. So I want to be respectful of folks' time. If you could go to the next slide, please. So there were some questions also if the slides and recordings will be posted. They will on our website, nashp.org/family-caregiving. You can find a bunch of resources there. And next slide. And again, thank you all so much for attending. Thank you to our speakers, Pam, Jason, and Nicole. And please fill out the evaluation as you exit today's webinar, but thank you so much for joining us, and thank you again to our funders, the Administration for Community Living and the John A. Hartford Foundation. Have a great day, everyone.